Good evening and welcome to Doctors on Call. I'm Dr. Joseph Lemker, an orthopedic surgeon with the Community Memorial Hospital in Cloquet, and I'm your host for your program tonight on lower extremity, knee, foot, and hip problems. The success of this program is very dependent on our viewers. Please call in your questions and we will do our best to address them. The telephone numbers for your questions can be found at the bottom of your screen. Our panelists this evening include Dr. Ann Norman, an orthopedic surgeon from Essentia Health, Dr. David Rust, an orthopedic surgeon with St. Luke's Orthopedics and Sports Medicine, and Dr. Joel Zamzo, an orthopedic surgeon with Orthopedic Associates of Duluth. Our medical students answering phones tonight are Elliot Jacobson of Alexandria, Minnesota, Morgan Kessler of St. Michael, Minnesota, and Alex Kraft of Cut Bank, Montana. Now on to tonight's program on lower extremity, knee, foot, and hip problems. And thank you for joining us tonight. Starting out, as we're waiting for some of the questions that come in from other people, I'd like to start maybe with Joel tonight. As we're seeing increasing numbers of people coming into our offices with hip arthritis, hip pain, and even at younger age groups, and we're already going to see numbers elevating from hip and doubling from 300 to 600 and 500,000 to 1.5 million over the next 20 and 30 years is what we're seeing projecting. How are you addressing some of your patients coming in, especially at the younger age groups?
Well, I think the younger age groups you try to put off as long as you can. Mm-hmm. Weight loss, exercise, anti-inflammatories, injections. But boy, when the pain is bone on bone, mm-hmm. I think there's no choice except to do the hip replacement. I had my partner do my hip replacement mm-hmm. 5 years ago. I was 53, pretty young, but I really had gotten to the point where I couldn't walk. I had terrible mm-hmm. pain. It's a miracle of orthopedic surgery to be able to mm-hmm. sit here and continue to practice, because I would have had to retire without successful hip surgery. So as much as it's such a growing entity of arthritis, mm-hmm. the solution is really very effective and life-changing.
Dr. Rust, what kind of options are you giving your patients even prior to maybe doing some of the surgical options?
Well, I think the most important thing to tell patients is that activity is actually beneficial for people that have degenerative joint problems. I think there's a lot of misconception. People are told, oh, if your joint is wearing out, whether it's your hip or your knee or your shoulder, you should stop doing these activities that you like to do because you're going to cause more damage. But in the reality, the healthier you are as a person, the more you exercise, the more active you are, the more you keep your muscles fit and you keep the mobility in the joint, the longer you're going to preserve that joint. And if you can delay the surgery until the x-rays show more advanced degeneration and you can maintain an active lifestyle, not only are you delaying that joint replacement surgery, but you're also making yourself a better candidate for surgery. You're making your recovery healthier, mm-hmm. and hopefully avoiding some of the potential complications that can come with joint replacement surgery.
Mm-hmm. And Dr. Norman, as we're seeing a lot of in the news, like minimally invasive and different techniques of putting joints in, whether it be for the knee or the hip, and faster recoveries, how do you address that, and which patients you think are candidates for those type of procedures?
I think the fundamentals that both of you have talked about so well are still the same. You want to have good range of motion, mm-hmm. good strength, good overall health. All of that's going to make your recovery mm-hmm. that much easier no matter how the surgery is done. Mm-hmm. My techniques are fairly similar. We always try to minimize the amount of soft tissue that we're opening up and moving around, because that does help patients with pain control later on and with recovery. So I think everyone's a candidate for trying to use the new techniques, but the principles are always the same.
Mm-hmm. And as we're seeing also lately, a lot of the push these days, even sometimes from insurance companies, to have earlier releases from hospitals, either next day, same day, or a couple of days. And so I think a lot of the issues with some of the patients is the fear of the unknown. Are they going to be ready to go? Are they going to be, what's their pain control? How are they going to do their therapy? How do you address some of those issues, especially when they're being addressed, or sometimes even insurance companies now are driving that is trying to get them out on either same day or next day?
I think a lot of that comes to patient expectation and trying to have that discussion before they enter the hospital. That's really the key. I'm not one to rush people out of the hospital, but there's no doubt that that's the trend, and it will continue to be the case. It's these are, cost to society is a big deal, and I think that's really where this push comes to kind of try to keep some reasonable lid on healthcare costs. But I think a lot of this is the patient expectations and getting the families involved ahead of time. And I think you always hate to hear this when patients come into the hospital and they're like, well, what are you going to do after your hospital stay? And they look at you like, well, I haven't really thought about it. And it's like, oh, it's kind of like, but so I think this starts before surgery.
Yeah, true.
Yeah, I agree with that completely. I think it all starts before surgery. I tell patients that having a joint replacement surgery is like running grandma's marathon. And if you were to expect to get off the couch tomorrow and just run a marathon, you're going to feel terrible afterwards. Your body's going to be sore, depleted. But if you can train and you can prepare yourself, it's amazing when we look at the outcomes for patients that do get up and move early after surgery, whether it's discharge the day after surgery, or even some places that are doing outpatient total joint replacement surgery. Those results are actually better than a lot of the ways the patients that were staying in the hospital 3 or 4 days in the past. And I think it comes down to preparation. If you prepare yourself for the surgery and you get yourself in shape and you're ready to recover from the surgery, you can have a very healthy, very quick recovery, and it may be less dependent on the minimally invasive or the surgical technique, and just how is the patient actually preparing for the surgery and ready to undergo that recovery.
And sorry, just to interject, but I was going to say anesthesia has been a huge part of this. My God, what they're doing with blocks and lessening the pain, and people will have much less pain because of that. That's been a huge deal.
And the final thing, I think, is everything that we were talking about before with optimizing your health, your well-being, your range of motion, and your strength. I think if you can do all of those things, patients are much more capable of getting up, going home, and taking part in that active recovery. I also have my pre-op talk where, it's the surgery is one part of this, the rehab is the second phase, and they're both critical.
I agree. I think as we see, incorporating other modalities as far as pain control, incorporating the stuff that anesthesia can do for us, with blocks, and also multimodal pain control, and also, as you mentioned, preoperative programs, whether it be physical therapy, get them prepared, but also having the whole team on board, I think mitigates a lot of their fear of some of the earlier discharges, and I agree they do very well as you do that ahead of time. Now we're starting to get some questions in from outside. Here's one from Karen from Moose Lake, Minnesota. Is running actually bad for your knees? Dr. Rust?
So, great question, and I always tell patients there was some early studies done even in the 1990s that they took marathon and distance runners that had early arthritis in their knees, and they compared those to the same group of patients who were sedentary that had early arthritis but were not active, and they followed those patients over many years, and over 15 to 20 years the arthritis in the patients that were sedentary was not any less than the patients that were runners. So it's not that running is bad for your knees. The activities do not cause arthritis and degenerative disease to worsen. It's probably more due to your genetic makeup. It's due to what you're eating, the types of foods that you're putting in your body. If you're eating a lot of processed food and high sugars, we know that increases body inflammation, and that can lead to degeneration. So I think it really comes down to staying active, keeping your body active, and if you do that, there's no reason that you can't do an activity like running and still have longevity in your joints.
Great, thank you. Another question from Ruth from Two Harbors, Minnesota. Dr. Norman, why are my legs going numb below the knees when I run?
That could be several different factors. There are several conditions that can affect tissues even upstream or above your legs and knees. Nerve irritation coming from your spine, coming from the back of your thigh. What we typically call sciatica can sometimes give you those sensations. There are some other more localized issues with the muscles below the knee. And then the final thing to consider would be circulation. So I think getting a few different areas checked would be important.
Right. This one is directed actually to Dr. Zamzo, came in and got a fan out of Virginia. Any new treatment for foot drop other than therapy and exercise?
Well, it kind of again depends what the foot drop's from. I actually had a foot drop with a disc herniation, and Bill Humango did my surgery, did a beautiful job for me. So that's just too not specific to be able to answer, but you certainly would like to understand the cause of the foot drop and then treat accordingly. And if it's a disc, recovery will be great. It could be nerve compression at the knee, the peroneal nerve. So probably a good orthopedic and neurological evaluation, EMGs, diagnostic studies. There'll be probably a solution that probably is able to fix that unless it's chronic, and sometimes they are if there's been an injury, for example.
Yeah. And here's one from Elliot, 24 years old male from Duluth. What measures as a young person should I take to ensure my joints remain strong into my later years? Dr. Rust.
I seem to be getting on the same topic.
Yeah.
So I think number one is certainly overall body health. So when we talk about exercise, it really comes back to a lot of the basics that you learn when you're younger: cardiovascular fitness, muscle strengthening, joint mobility. And then another one that's really important, and this becomes bigger issue later on, is balance. And so when you're trying to keep your body healthy, you have to really do a well-balanced exercise program. And there's lots of them out there. There's lots of gyms out there. There's lots on available on the internet. There's lots of blogs and different email groups and support groups. So I think that's the main thing is your overall exercise and body health. And then you look at things like your diet and making sure that you're eating healthy foods. One of my mantras is if it's colorful and it grew in the ground, you can probably eat as much of it as you want. If it came in a bag or it's got a bunch of sugar or you got it at a fast food restaurant, it's probably not good to eat a lot of that. Well balanced. Everybody should have moderation for those things that they really enjoy. So none of us are perfect, but
great tips. Dr. Norman, here's one from Tom from Cloquet. What is pseudogout?
So pseudogout is a condition in which our bodies create crystals, little firm deposits of tissue, and they can settle out in joints and they can be highly irritating, causing a lot of inflammation, pain, and swelling. Gout is the thing that we think of more commonly. Pseudogout is similar. It's not, the crystals look a little bit different when we look at them in the lab. It's usually managed with anti-inflammatories and once in a while aspirating the knee and injecting.
Yeah. Here's one from Dave in Duluth. What is peripheral neuropathy? How is it diagnosed and treated, Dr. Zamzo?
Well, peripheral neuropathy, the most common cause is diabetes in today's society. There are other causes. It's like I said, for example, diabetes, the best treatment of that is good diabetic control. That's the only thing that's been shown to really make a difference.
Yeah.
There are other causes. They're rare, vitamin deficiencies, things like that. Infectious diseases years ago did cause peripheral neuropathy, but those type of disease we don't really see too much anymore.
Okay.
So mainly probably diabetic control,
Yeah.
if that's what the cause of it.
Dr. Rust, here's one from Jake from Clam Lake. He had partial hip replacement, 65 years. He fell off a ladder. He's now a year out. Why do they not replace the whole hip? And it has sharp pain and feels a knocking periodically when he walks or twists.
Well, that's a good question, and the answer is that they, in a lot of places, they do a total hip replacement for a broken hip. That doesn't mean that that's the best solution for a given injury. You know, a partial hip replacement is certainly the standard of care for most hip fractures, but they have looked at doing total hip replacements in younger active patients, knowing that a partial hip replacement, if you're active on that partial hip replacement, you may develop arthritis in the hip, and ultimately, if there is ongoing pain and that other half of the hip that hasn't been replaced is worn out, then a joint replacement surgeon might be able to go and replace the other half of the hip. So convert that partial hip replacement to a total hip replacement and maybe treat some of the pain and symptoms. But you know, obviously there's other reasons that you could have pain, so you just want to make sure that you're getting a good evaluation and have them look at all the possible reasons why you're having pain. But that certainly could be one possible solution to that answer.
Dr. Norman, here's from Denise in Duluth. How do you diagnose a joint implant allergy and how do you treat that?
So usually we refer to our colleagues who are allergists and they can do a variety of different tests for reactions to the metals. Nickel would be one of the components of some of these implants that sometimes does cause a reaction, but it's pretty rare. But I would probably start with a conversation and a referral to an allergist.
Yeah, and I think that's a controversial subject too. It's interesting that people that have nickel sensitivity on their skin from jewelry, there have been many studies at like the Mayo Clinic that have shown that the stainless steel implants in the body do not produce the same allergic reaction. And so even just the thought that nickel allergy may cause sensitivity after joint replacement surgery may not even be true at all. And some groups of orthopedic surgeons believe that it's possible to have a nickel allergy and that you can undergo a revision surgery to address that. And other whole groups of orthopedic surgeons don't even really believe that that's the cause and would look at other causes of pain and treating other parts of that pain. So it's a controversial topic, very difficult. The allergists don't always give you a great answer, and so it can be a really tough problem.
It's almost like a different part of the immune system, the skin, our external world compared to our internal world of our joints.
Yeah. And I agree. It depends on allergists too. A lot of allergists I've discussed with aren't convinced that it's correlative.
Because we used to do some skin testing, but it's really a gray area, and I don't think you can hang your hat on it.
Yeah, and there's some question too that it may be some other components of the surgery, like the bone cement, and so they'll sometimes test for bone cement allergies. But it's a really hard problem to treat, and for patients that are suffering from pain after joint replacement surgery, it can just be a really hard thing to try to go through all those different possibilities and try to come up with an answer. And you know, sometimes we really don't end up having a good answer for them.
And I think almost all the total knees have some nickel component. That's not true with hips, titanium, but knees, I think even the less nickel, there's still some. So that's a tough topic.
It's a very challenging one.
How does the condition of osteoporosis factor into these surgeries, such as total hips and knees, from Judy in Two Harbors? Ann?
So Looking at osteoporosis becomes important when we consider what types of implants. Again, staying active, trying to do weight-bearing activity, lifting weights, building muscle strength is important to help protect those bones. In my opinion, looking at osteoporosis as a factor, it comes in a little bit more in the hips where we can choose different implants. We have some that the bone grows into and others where we use the bone cement to hold the implants in place. And someone with osteoporosis that's advanced, I would be more likely to use a cemented implant so that you have immediate stability. You're not relying on the weakened bone. In the knees, the usual approach is bone cement anyway, so it's not quite as decisive, or it's not as big a factor in making a decision on what to use.
Dr. Rust, here's a question about doing joint surgery, but not until after diabetes is under control. They're questioning why can't you start it earlier, and if they can't exercise, how do they get their diabetes under control?
Yep. So there's some growing push towards having national guidelines for what amount of what factors are acceptable and what factors should really be hard conditions that stop you from being able to have an elective joint replacement surgery. And one of the big ones is diabetes, because the complication rates with joint replacement surgeries, although they're fairly low, the complications that we do see can be terrible. And the biggest one is infection. And we know that diabetes may be the single biggest factor. That and body mass index, or obesity, are two of the main factors. So if you look at the healthcare systems across the country that are kind of leading the way in some of the research behind this, so the Mayo Clinic, Johns Hopkins, Hospital for Special Surgeries, the Cleveland Clinic, in general, the cutoff for joint replacement surgery is a hemoglobin A1C of about 7.5. And that's a pretty acceptable number for a surgeon to be able to say, you know, this is not the right option for you at this time. Because we know that if you can bring that blood sugar back under control, you can reduce your risk of an infection by 3 or 4-fold, which is a huge number when you start to factor in the number of joint replacement surgeries that need to be done nationwide and in our community. So getting the blood sugars under control, very difficult problem. It requires a combination of being on the correct medications, being on the correct foods. It can mean big lifestyle changes for people. It can mean trying to incorporate exercise and weight loss into their daily routine, which is a really difficult thing for people to do. There are modified exercise programs that are less impactful. You know, there are resources through like the YMCA and through the, like Essentia's got their wellness center where you can actually get, you know, some one-on-one counseling either with a nutritionist or with a personal trainer or a therapist that can help you achieve those goals, because we know that the joint replacements are helpful. That the satisfaction and the outcomes are just as good for people who are overweight or have these conditions. And so we want to be able to say yes to doing these joint replacements, but we know that for patients who don't have their diabetes well controlled, if they don't have their obesity well controlled, the risk of those complications and what that can mean to their lives and their families' lives is just too much to be able to say yes, 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 yes. We have to have some kind of guidelines to be able to say, we need to hold back. We need to wait and get this under control so that we can do this surgery for you and give you the best chance of having success.
Right. Yep. And you know, the ramifications of having an infection are much worse than waiting and getting it under control, like you said. Here's a question from Alice in Duluth, Dr. Zamzo. Direct anterior hip replacement and still having some nerve pain in the upper thigh. What can help?
Well, you'd hope that with time that would get better. The femoral nerve is at risk for that approach. Nerve can regenerate if it's, depending on the injury pattern can recover a millimeter a day as far as some of it. So sometimes it's just simply a traction injury and gets better very quickly.
Yep.
But it is a risk of the anterior approach, no doubt.
Yep, that approach, that lateral femoral cutaneous nerve comes right by
there,
that area.
right there.
And takes a lot of traction. A lot of times people will get some numbness or some nerve pain that go down the lateral thigh.
And it usually gets better quickly, and ultimately it can recover as long as a millimeter, take as long as 1 millimeter per day.
Yep. Do we have time for one more question? Yeah? Here's one from Kathy from Aurora. 65-year-old, full hip replacement 3 years ago and having trouble with bursa. Is there anything you can do to help?
Bursitis is challenging. It can take a lot of work. Sometimes there are exercises that will help, anti-inflammatories. Some people will inject with a hip replacement in there. You may want to think twice about that because the risk of infection is there. I usually will have people start with a therapy program, anti-inflammatories, ice, heat, whatever makes you feel better, but it can be challenging.
30 seconds. I want to thank our panelists at this time, Dr. Ann Norman, Dr. David Rust, and Dr. Joel Zamzo, and our medical students, phone volunteers, Elliot Jacobson, Morgan Kessler, and Alex Kraft. Please join Dr. Ray Christensen in 4 weeks on December 12th for a program on upper extremity, neck, and back problems when his panelists will be Dr. Brad Kuzel, Dr. Glenn Rudolph, and Dr. John Stellaris. Thank you for watching, and good night.